Hello and welcome to Talking About Tumors with Ryan and Ryan. Just Ryan hosted today. And I'm going to be introducing the current approach to metastatic prostate cancer. Before I start, I just want to thank everyone who's been listening along. I truly appreciate those of you who've left a review on iTunes or on Spotify. To those of you who've found this helpful and have not yet placed a review online, please do so. It does help other people find the show. And also, we welcome any and all feedback. Feel free to email us or send us a message on Twitter. Today, we're going to do the initial introduction to metastatic prostate cancer. And as we mentioned in the previous discussions, the vast majority of patients with prostate cancer are diagnosed locally, treated definitively, and do not have a recurrence. Only about 6% of patients will be presented with de novo metastatic disease, and there will be a proportion of patients who have recurrence after initial localized therapy. Although many people do not die from prostate cancer, once you are presenting in the metastatic setting, the risk of mortality is much higher. The approach in this disease site has actually radically changed in the past decade, and we have seen improvements in overall survival. Prior to the incorporation of intensified chemotherapy, anti-hormonal therapy, the expected survival for metastatic disease was approximately 3 years. And once disease becomes resistant to anti-androgens, the prognosis has been much grimmer at about 1 year. Some of the trials we're going to be discussing about today do show improvements of overall survival even beyond 5 years, looking at to be approaching a median of 6 years. And in patients with treatment refractory disease, we are having an increased number of agents available. Important to keep in mind that although the measurements of survival have improved, I think this definitely can be attributed to the therapies that we're using, but we also have to take into account the more advanced imaging such as the PSMA PET scan and maybe catching this metastatic disease earlier. So you have to account for some lead time biases in these overall survival changes. It certainly has been impressive to see what has changed in this disease site, and as we were preparing for this discussion, really realized how many of these papers are still just publishing out in the last 2 to 3 years. And the field has rapidly changed since when I was even just starting my fellowship. I'm not sure if the approach where I was is consistent across all cancer centers, but typically when someone was found to have metastatic prostate cancer, they would usually be managed by their urologist or perhaps a radiation oncologist who would start androgen deprivation therapy, whether or not that was surgical or medical with the medications such as leuprolide or goserelin. Once the disease began to progress on anti-androgen therapy, this would then be called castrate-resistant disease, at which time patients typically would be referred to medical oncology to look for roles of systemic therapy such as chemotherapy. And as I've mentioned, usually when we get to this point, prognosis is quite grim. As the number of treatment options have exploded even at the time of initial presentation, it's been my experience, at least where I'm working now, that patients are being referred earlier and earlier to medical oncology. I would expect this to be fairly similar at multiple cancer centers. Just briefly on nomenclature, castrate-resistant disease does have a specific definition, and that is having 2 subsequent PSA measurements rising with testosterone in the castrate range at less than 50 nanograms per deciliter. It's also important to be mindful that depending on the presentation with metastatic disease, the anticipated prognosis will be variable. For patients presenting with de novo disease, this is likely going to be a higher risk presentation. However, those who've been previously treated locally, it's worth taking a look at their initial Gleason score, risk factors at the time of their initial diagnosis, and time from initial treatment to progression, as this can help get a better sense of the disease trajectory and behavior, and to help incorporate how you're going to manage this disease. As some patients who develop disease recurrence may be in their later years, into late 80s or even the age of 90s, some of the treatments we're discussing here today may not be the best ones appropriate. And it's important to have an idea of the patient's overall prognosis and goals of care with these later recurrences. Although not considered standard of care, incorporation of anti-androgen therapy alone, especially some of the less toxic regimens such as bicalutamide, may be used in clinical practice. As often these decisions require experience and careful selection, it's hard to give a if and when situation on the discussion today, so we'll focus more on what would be the standard of care at this time. And to help orient everyone, I'm going to be going through a little bit of history here and how we got to where we are today. Although the most common presentation of metastatic prostate cancer may be found during workup as asymptomatic lymph node or bony metastases, this may also present as symptomatic disease, most commonly being pain with bony involvement. However, rarely in more aggressive presentations, patients may present with visceral disease, which can present with abdominal complaints, liver dysfunction. You may see patients who have such a significant marrow infiltration that they're presenting actually with myelosuppression, so this may be actually diagnosed with a bone marrow biopsy. I've even seen some cases where patients present with profound DIC, and urgent initiation of systemic therapy with chemotherapy is indicated in those cases. For the sake of focusing in on the systemic therapy options, today we're going to just talk about patients who do have diagnosed metastatic disease. There is a unique situation where patients may have a rising PSA, no role for further localized definitive therapy, no evidence of distant disease on imaging, and we'll discuss that during our next discussion as we get into more advanced disease management as well as some of these less common scenarios. The reason that metastatic disease was typically approached with ADT alone is that our typical systemic therapy options were found to be quite ineffective in metastatic prostate cancer, and this was actually thought to be a chemo-refractory disease until 1996. Prior to 1996, there was some evidence to support the use of one chemotherapy, a topoisomerase II inhibitor, mitoxantrone, which is not unlike our anthracyclines, both in function and toxicity. And this did show in some patients could delay the time to painful progression and bony complaints, however, did not improve overall survival. It's worth noting that the mitoxantrone was given along with prednisone. Prior to the incorporation of mitoxantrone, the standard approach to patients who progressed on ADT alone would be incorporation of prednisone. It's also worth noting that in those patients who did have androgen resistance, they were continued on ADT, as this has been shown to be beneficial, possibly by slowing progression, even though the tumor has been shown to be mostly resistant to the anti-androgen therapy. It was not until 2004 where a pair of papers published simultaneously in New England Journal showed improvements in overall survival, and this was using docetaxel. In one of the papers, docetaxel was given along with prednisone, and the other was given along with exemestane. Currently, using prednisone has remained the standard of care due to similar survival in each and a lower risk of thrombotic complications with the prednisone. In each of these trials, median overall survival was about 17 to 18 months with the docetaxel group, which is about 2 to 3 months improved from the mitoxantrone arm. Of note, in one of the two papers that was run by Ian Tannock's group, a weekly docetaxel regimen was also incorporated. This was slightly better than mitoxantrone alone, however not as well as the every 3 weeks docetaxel group. I do mention this because occasionally in those patients with very aggressive disease, using a weekly regimen may be preferable from the standpoint of toxicity to get the disease under control prior to resuming standard every 3 week regimen. Beyond just improving survival, these regimens did show an improvement in quality of life by delaying time to developing painful bony symptoms, cord compression, or fracture. Once the survival is shown, the understandable next question is would there be some benefit of incorporating chemotherapy sooner and not waiting until the time of castrate resistance? The first study to look at earlier incorporation of docetaxel was a French trial by the GETUG-AFU group, and this was a 1-to-1 randomized trial that randomized patients with newly diagnosed metastatic prostate cancer to androgen deprivation therapy or androgen deprivation therapy, and 9 cycles of docetaxel given every 3 weeks. This trial had 80% power to detect an improvement in overall survival with a hazard ratio of 0.62. This trial did not show improvements in overall survival, but did increase progression-free survival by about 10 months. The hazard ratio for overall survival was 1.01. Some post-hoc evaluation of subgroups did find some of the patients with more aggressive disease appeared to maybe get a larger benefit from the earlier incorporation of docetaxel. But as we've previously discussed, subgroup analysis alone is not enough to make a final conclusion, and subsequent studies have since been published honing in on these higher risk populations. One of these studies was called the CHARTED trial, CHAARTED, run by the ECOG group. And this group also looked at patients with prostate cancer that has not yet been treated in the metastatic setting, and specifically enrolled patients by what was called high volume disease. So these would be patients with either visceral metastases or metastases including greater than 4 bones, one of which had to be outside the pelvis and vertebra. So basically demonstrating extensive disease expanding into either distant bones, far away from the prostate, or viscerally, which are both known to carry poor prognosis. In the ECOG trial, patients only received 6 cycles of docetaxel and had slower accrual at first. So a later modification did also allow for the inclusion of patients who did not meet the high volume definition. This trial had 80% power to detect an improvement in overall survival hazard ratio of 0.67 and did show an improvement in overall survival of 57 versus 44 months. When looking specifically at the high volume subgroup, median overall survival was greatly improved from 49 versus 32 months. Although during the initial report of this paper, there was a suggestion of improvements in overall survival for the low-risk group, at the follow-up analysis, this significance was lost. The other trial that looked at earlier incorporation of docetaxel in the hormone-sensitive state was the Stampede trial. We've discussed Stampede before. We mentioned that this was a multi-arm trial, so patients with prostate cancer in either early, middle, or late stage were enrolled in this trial, and depending on their extent of disease, they would be put into a different bucket. So in the case of this particular Stampede arm, they looked at all patients with de novo metastatic disease, and of note, it did include some patients with high-risk localized disease. The high-risk localized disease did not get benefit from docetaxel, so I won't discuss them further here. In this trial, there was actually 4 arms. One arm got androgen deprivation therapy alone, standard of care at the time. One arm got androgen deprivation therapy and zoledronic acid, drawing upon our previous evidence in other bony disease that zoledronic acid can be beneficial. Third arm got androgen deprivation therapy and docetaxel, and the fourth arm got all 3, so androgen deprivation therapy, docetaxel, zoledronic acid. Zoledronic acid did not appear to have any benefit in the hormone-sensitive space. I should mention that bone-modifying agents have been shown to delay time to fracture and symptoms in the castrate-resistant space. So when you have a patient that becomes resistant to your initial therapy, has a rising PSA despite castrate-level testosterone, incorporation of a bone-modifying agent such as zoledronic acid or denosumab would be standard of care at this time. However, in the earlier phase, based upon the results of the Stampede trial, this would not be a necessary medication to include. In terms of focusing on the primary question here, which is did docetaxel improve overall survival in de novo metastatic disease, the trial did have a hazard ratio of 0.78. Note that this is less than the hazard ratio of 0.67 shown in the charted, but this was because there was the lower risk population incorporated within the overall group. The benefit did once again appear to be greatest in those with the higher risk disease. So in short, these 3 trials have built the story that, at least in high volume disease, earlier incorporation of docetaxel does improve survival. And those without high volume disease, but with de novo metastatic presentations, so not patients with a late recurrence, but those who are metastatic from day 1, perhaps those patients would also benefit from docetaxel, as those were patients enrolled in the Stampede trial. Another major shift in management of prostate cancer was happening simultaneously as these trials were accruing patients and awaiting final overall survival results. We discussed this in our adjuvant discussion previously, and that was the incorporation of what were then known as novel anti-androgen therapies, also may be called advanced anti-androgen therapies. These are the drugs such as abiraterone, enzalutamide, apalutamide, and darolutamide. We've previously mentioned these have now become very commonplace in the management of metastatic prostate cancer, and as with docetaxel, these had initially shown their benefit in the castrate-resistant space before translating into the earlier setting. Evidence for abiraterone was the first to emerge in the castrate-sensitive space, and this was with 2 trials. One was another of the subgroups of the Stampede group of trials, and the other was Latitude. In both of these trials, abiraterone was given to patients with newly diagnosed metastatic castrate-sensitive disease, and remember that when we give abiraterone in the castrate-sensitive space, we give it along with prednisone 5 milligrams daily, as compared to the 5 milligrams BID regimen used in the castrate-resistant setting. The inclusion criteria for these trials also looked at a higher risk population, namely in the Latitude, the definition of high risk was used. So we talked about high volume with the charted trial. With Latitude, the criteria were called high risk, and patients had to have 2 of the 3 following criteria. Gleason score greater than or equal to 8 at the time of initial diagnosis, greater than or equal to 3 bony lesions, or evidence of visceral disease. So fairly similar to high volume, although the initial Gleason score was also used as a high risk criteria. Both these are randomized trials incorporating the use of abiraterone daily versus ADT alone. Keep in mind with the docetaxel trials, we were talking about time-limited use of docetaxel, so only 6 cycles. Whereas here, it would be ongoing abiraterone until progression. In this case, we had a significant improvement in overall survival. For the Latitude trial, median overall survival was increased from 36 months with ADT alone, consistent with our previous evidence that approximately 3 years is the average survival with de novo metastatic disease, versus 53 months with abiraterone. In terms of the Stampede trial, this had also included low-risk patients and high-risk localized disease, and in general had overall survival across the board. So the upshot of all this at the time of these trials, which were published around 2017 and 2019, was that with patients with high volume or high risk metastatic prostate cancer, early incorporation of therapy in addition to ADT alone did improve overall survival. It looks as if the added absolute benefit was relatively similar whether you use docetaxel alone or abiraterone alone, and often the discussion I would have with patients would be between whether or not using time-limited docetaxel or continuous abiraterone, also balancing the toxicities and the patient comorbidities. Keep in mind in both cases, even with the time-limited docetaxel, ADT would be continued indefinitely, and patients should be canceled on the side effects that come along with that. Over the subsequent years, we've also had trials publishing out looking at enzalutamide, apalutamide, and darolutamide. I'm sure there's going to be more coming. As with many disease sites, once there's a few Me Too drugs, many more proliferate. The survival benefit when looking across the board to the abiraterone and docetaxel trials seems about similar. It's difficult because, once you talk about between trial comparisons and trials that are done at a later time, you have patients getting increasing access off trial to some of these effective agents. And in general, the overall survival tends to skew positive. Ultimately, when it comes to the oral agents, whether that's our enzalutamide direct anti-androgen class or our abiraterone anti-hormonal synthesis class, it's worth sometimes looking at differences in toxicity. In terms of enzalutamide, apalutamide, and darolutamide, toxicities do appear somewhat similar. There are some subtle differences between the two. All have an increased risk of falls, hypertension, fatigue, risk of congestive heart failure, which can arise symptomatically at the range of about 2%. There do seem to be a higher risk of rash with apalutamide, which was reported up to about a quarter of patients, and diarrhea was seen in about 20% of patients with apalutamide. Darolutamide seems to have the highest risk of LFT elevations, and enzalutamide notably had the initial highest rate of falls and risk of seizure estimated around 1%. Of note, the later drugs do seem to have similar rates of falls as more and more studies have published out. However, the seizure rate still does seem to maybe slightly higher in enzalutamide. Once again, about 1% risk of seizure, but something worth definitely talking to your patients about. Other things to keep in mind when you're choosing between the 4 oral agents is to be mindful of the patient's other medications because these are all metabolized differently. There may or may not be significant interactions with the patient's prior medications. Naturally, as we have 2 classes of medication showing improvement in survival in this setting, the next question would be, is there further synergistic benefit and improvements further in overall survival by including both the novel anti-androgen as well as chemotherapy at the time of presentation? And this has since been addressed in randomized trials that were initially run to look at this, but was first studied in the ENZAMET trial. The ENZAMET trial was initially designed for all risk patients with newly diagnosed castrate-sensitive metastatic prostate cancer, and they were randomized to enzalutamide versus enzalutamide and ADT, not unlike our STAMPEDE or CHARTED trials. Noting, though, however, this did not include only high-risk patients, but all patients with metastatic disease. This trial had only accrued about 50% when the CHARTED data came out showing improvements in survival with docetaxel. So they did allow patients to have docetaxel and then begin enzalutamide. This was not mandated. About 48% of the patients in either arm, both the enzalutamide arm and ADT alone arm, got docetaxel, which would be fairly consistent with what we would expect to see because about 50% of the patients in this trial had high volume disease. Although this trial was not comparing enzalutamide plus docetaxel versus ADT alone, it was seeing whether or not, after administering docetaxel, whether or not enzalutamide could further improve survival. And this trial was positive for overall survival. The hazard ratio was 0.7. However, in subgroup analysis, this survival benefit was lost in patients receiving docetaxel. Looking further detail at the patients who seemed to benefit from enzalutamide docetaxel, it seemed to be most beneficial in patients with de novo metastatic disease. They did not give subgroups about high-risk or low-risk patients, so I wonder how many of the high-risk patients would have also benefited. But in general, we can think of patients with de novo metastatic disease as being more likely to have higher risk presentation, as in the patients with prior definitive treated disease are being watched closer, and you would expect to have their PSA caught in metastatic disease caught in an earlier setting. So this has been studied a bit more definitively in the PEACE 1 trial, which was initially designed as a 1-to-1-to-1-to-1 trial for all patients with de novo metastatic disease. This is asking a few hypotheses, whether or not adding abiraterone to standard of care alone or radiation abiraterone to localized disease for metastatic disease would improve overall survival. However, in light of this emerging evidence in the other trials, this trial was subsequently amended, first in 2015 to allow docetaxel, much like the ENZAMET trial, but then in 2017 was mandated to incorporate docetaxel, and the primary hypothesis began to focus on whether or not docetaxel plus abiraterone was better than docetaxel alone, both arms, of course, getting ADT. So whenever we amend trials, we need to enroll more patients in order to still obtain the same power. And this was ultimately powered for an overall survival benefit with a hazard ratio of 0.7 with a power of 80%. And no interim analyses were done because this would eat into the power calculation after so many amendments. This patient population did have a high rate of high volume disease. About 60% of the patients would meet the high volume criteria. And this was a positive trial. So the hazard ratio ended up being 0.75 with the docetaxel median overall survival not yet being shown versus 44 months. First look at the overall survival curves. There's about a 1.5 year survival benefit, although we'll have to wait for the data to mature to be more confident. So it's a fairly large trial, about 355 patients in either group. And those that only received docetaxel and androgen deprivation therapy, about 80% of them got some form of androgen, advanced androgen agent on progression. 80% of patients on progression getting a medication like abiraterone, enzalutamide, apalutamide, or darolutamide would be what we would expect to see. However, many trials, and we'll get to a few of these in the metastatic castrate-resistant space, did not always show such a high rate of post-protocol standard of care therapy. Keep in mind, all these other agents had previously shown benefit in the castrate-resistant setting. So we really want to know, incorporating them early, does that improve overall survival, assuming we would give them on the back end? And this Peace 1 trial, I think, did a really good job of addressing that question. And I think gives a good answer that for high-risk patients, more drug does appear to be beneficial to be incorporated earlier. Understandably, this did have a higher rate of toxicity. However, grade 5 or greater events was not significantly notable in either arm. A bit more of a smoother trial than the Peace 1 trial was the ARATs trial, which used darolutamide in castrate-sensitive metastatic prostate cancer. This mandated docetaxel from the initial development. Darolutamide is a newer agent, so a lot of its trials were initiated at a later time. This was a large trial, had 650 patients in either arm, and about 86% of these patients were de novo metastatic. In general, slightly higher risk patients. The median PSA was 30. This trial had 90% power to detect a hazard ratio of 0.75 for overall survival. And as I mentioned, these were appearing to be high-risk patients, although they did not use the high-risk criteria that or high-volume criteria that we've seen in the charted in Latitude trials. The overall survival was improved. Hazard ratio was 0.68. Of note, in this study, only 3/4 of the patients in the placebo arm ended up getting a novel anti-androgen later on, which is less than ideal. At 4 years, the overall survival was 63% versus 50%. A later follow-up publication did look at the risk groups for the ARASENS trial, and they did analysis of both high volume and high risk criteria. Only 23% of patients had low volume and 30% fell into the low risk criteria, and the benefits seemed to be greatest in the high risk, high volume patients. They did find in patients who had low volume alone, so not the low volume, low risk, but just all the patients low volume. So there, in theory, would be some high risk patients with a higher Gleason score and mixed in among this population. Did have a hazard ratio of 0.68. Overall, the overall outcomes in these patients appeared quite well. So I'm not sure how much of an added benefit these low volume variable risk rate patients benefited from the triplet therapy early on. There did seem to be some added benefit in the patients who met low risk criteria. So not the low risk and low volume criteria combined, but low risk criteria, which would invariably incorporate some patient who would meet high volume disease, but not meet the 2 of 3 high risk criteria. It's kind of a messy way of explaining it, but essentially there did seem to be a statistically significant benefit in this post hoc subgroup. But I think the general take home when we look at this follow-up paper published by Dr. Hussain et al. In the JCO in 2023 is that the triplet therapy seems to be most beneficial in improving overall survival with people with either high volume or high risk disease, de novo metastatic disease, with maybe some carefully selected patients who would traditionally fall into the low risk criteria, warranting more intensified therapy. How to choose those patients, I'm not so sure is easy. So I think it's important to keep in mind that all these trials I've discussed in the castrate-sensitive space have emerged since 2012. So we're talking about 10 years where numerous new drugs have been approved both in the castrate-resistant setting, moved into the earlier stage, and showing an improved overall survival. Although this seems to be par for the course when we look across many of our oncology subgroups. Prostate cancer is one of these diseases that really didn't have a whole lot of major changes for quite some time up until this revolution. And I think it really paints a picture of how developing a new way to treat a disease can lead to a cascade of very significant trials and really improving in outcomes. We're not able to cure metastatic prostate cancer, but when we're talking about survivals going up by median of 3 years, which would have been the standard with ADT alone in the castrate-sensitive space, to moving into 5 or 6 years, depending on the patient's risk groups, that is a clinically significant improvement in survival. This isn't a couple months. This is years of life we're adding to these patients. At the cost of toxicity. I mean, these anti-androgen deprivation therapy is not pleasant on its own, and now we're adding on some additional fatigue, risk of falls, chemotherapy toxicity, and all that comes along with docetaxel. But for those of you who've treated prostate cancer, I'm sure you've seen many people find those medications to be generally tolerable. And we have to focus on trying to find the combination that works best for those who do get the side effects, but for those who do well, these are really beneficial medications for their overall quality of life. And as we continue to get more agents arising in the castrate-resistant setting, we've been able to continue to modify that survival benefit further. It does make it hard to keep up with the sheer number of publications that have changed management and often replacing the private paper in short succession. I think it is important to have kind of gone over these drugs and how we've got to where we are before we start to talk about some of the other newer agents being studied in the castrate-resistant space next discussion. So tying this all together, in patients who have radiographic apparent recurrent disease or de novo metastatic disease, we're no longer using ADT alone in the vast majority of our patients. We're going to be incorporating either a novel anti-androgen such as abiraterone, enzalutamide, darolutamide, or apalutamide, and in some cases also incorporating docetaxel. If a patient has low volume, low risk, so not having visceral disease, having less than 4 bony lesions, or not meeting 2 of the 3 high-risk criteria, greater than 4 or equal bony lesions, visceral disease, Gleason 8, then likely in anti-androgens such as abiraterone, darolutamide, enzalutamide, or apalutamide, 2 ADT alone can improve overall survival and it would be generally continued until progression occurs. In patients with high volume disease or high risk disease, or perhaps young patients with de novo metastatic disease, where you really want to delay that time to castrate resistance as long as possible. This may also be the patient with a large bony lesion that you're concerned about risk of core compression or fracture. Earlier incorporation of docetaxel is beneficial. And the docetaxel is given standard as every 3 weeks for a total of 6 cycles. We do not incorporate zoledronic acid in the castrate-sensitive space, but will consider it, or denosumab in the castrate-resistant setting. It has shown improvements delaying risk of fracture and bony events in that setting. Worth mentioning once again, as mentioned at the start of this discussion, there are going to be some patients with very late, slow-growing, maybe 1 or 2 asymptomatic bony lesions at later years of life. And in those cases, perhaps the added toxicity of abiraterone would not be beneficial for your patient. This would especially be in patients with significant cardiac risk factors, which could be exacerbated by ADT or abiraterone. In those patients, you may consider using bicalutamide alone, but this would not be considered a standard option and should be really reserved for only the frailest patients who could still add some benefit by delaying progression. Once again, keep in mind, we always continue our androgen deprivation. There is some evidence existing for enzalutamide to be given as a monotherapy. However, those patients did not really get a significant reduction in toxicity with enzalutamide alone and did have a higher risk of gynecomastia, which can be painful. So currently, it would still be the standard of care to continue some form of androgen deprivation in addition to your anti-androgen. I hope this was a helpful overview. During our next discussion, we're going to discuss patients with biochemical recurrence, but radiographic occult disease, and the approach to layer line therapies. Take care. Hope everyone's doing well this winter. Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.